first gentleman is a 65-year-old man who's been a smoker since the age of 14. He also has hypertension, hyperlipidemia. He's a type 2 diabetic, and he presented with very severe bilateral lower extremity claudication after only 50 steps. And his symptoms were worse on the right than they were on the left. He had a CTA and angiography at an outside hospital, and this confirmed occlusive severe calcific disease of the right iliac vessels with severe calcific non-obstructive disease or non-occlusive disease of the left iliac common femoral, and he also had some moderate SFA disease as well. At the outside hospital, they did attempt a right iliac CTA traversal from a retrograde common femoral access. Unfortunately, this was unsuccessful. The local vascular surgeon felt that his vessels were so calcified that they were prohibitive to allow for cross-clamping, and thus he was deemed not a candidate for an aortobifemoral bypass. So he was referred to our institution and an attempt at PVI. And our plan moving forward after having reviewed his imaging studies was a left brachial access for both antegrade angiography and for antegrade treatment of the left iliac disease, followed by attempted right iliac traversal from both antegrade and retrograde approaches, ultimately with intravascular lithotripsy and stenting of the bilateral iliacs and IVL and DCB of his left common femoral access. This is his initial CT scan, and you can see all that white stuff. That is dense calcium, my friends. And you can see it's very occlusive there, particularly at the bifurcation. On the contrast angiogram, you can see that there is a subtotaled stenosis at the origin of the left common iliac. The left common femoral artery also has very severe calcification. And you can see that the right common iliac is flush occluded, and the external iliac is occluded as well, with reconstitution at the top of the femoral head. So we knew this was going to be a tough case, but fortunately, with our access from above, we were able to successfully deliver an 014 wire into the SFA. And this was followed by predilatation of that dense common femoral stenosis with a 4 millimeter balloon. And then definitive therapy, of course, was with a 7 millimeter by 60 millimeter intravascular lithotripsy balloon. And we used that balloon to then go ahead and traverse the external iliac artery and then further up into the common iliac as well. And you can see that after that 7 millimeter vessel prep with the Shockwave balloon, we've got a nice restoration of antegrade flow, but we still have some work to do. There's still a little meat on that bone. And so at this point, we decided we really needed to upsize for the bunker buster. And so we decided to take an 8 millimeter L6 device, and we basically just let it sit there and let it do the work. You know, in golf, they always talk about let the club do the work. And with IVL, let the L6 do the work. Just sit there and be patient and just treat it with an adequate number of pulses. And you can see that we had a nice release of the waste on the balloon, and we're able to get a full expansion of that area. And a very nice result after adjunctive treatment with the bunker buster. We then treated the common femoral with a 7 millimeter Ranger DCB, and then placed a couple of overlapping self-expanding bare metal stents, post-dilated those with a nice improvement in antegrade flow. And it was at that point we decided it was time to turn our attention to that nasty right common iliac artery occlusion. And again, you can see a very long, densely calcified occlusion. We obtained ultrasound-guided access with a micropuncture kit, which is what we always do. That's our regular pattern. And then we're able to put a very short 4 French sheath in there, and you can see that there's an ambiguous distal cap there, right at the junction of the external iliac and the common femoral. Initially, we tried to traverse that with a front-runner controlled microdissection catheter. Unfortunately, the device did go subintimal, and we also tried a wingman device and an escalating wire strategy. And although we came awfully close, we could tell that we were still just subintimal in the wall of the aorta. So at this point, it was time to just try from an antegrade approach. And so we delivered a multi-purpose guiding catheter into the presumed origin and stump of the right common iliac artery. And then also through that delivered a 0.018-inch Navicross support catheter in sort of a mother and child technique. And fortunately, with that particular regimen, we were able to successfully traverse that occlusion. We're able to deliver that wire into the SFA. And as you saw in the last slide there, gentle predilatation with a small 4 mm balloon, followed by slightly more aggressive predilatation with a 6 mm balloon. But really nothing to be concerned about because, again, we had the bunker buster. So we took the L6 8x30 all the way down from the external iliac back to the common iliac. And you can see a much better luminal improvement. Obviously, we still have some dissection there. And this was treated straight away with a couple of overlapping self-expanding stents. And at that point, we had basically just needed to come back and reconstruct the iliac bifurcation. Now, given the dense calcification here, we elected to choose 2 balloon expandable stent grafts. So these were VBX 8 mm stent grafts, and we deployed them simultaneously. And you can see a great result there. Post eyelid, both of those stents with 9 mm balloons, and really a spectacular final result. And if we look at the before and after, it was really just like night and day. This patient's symptoms were completely resolved, and he was absolutely delighted. So what did we learn from that case? How do we measure success? Well, we measure success by how the patient does. And he was completely asymptomatic. So it doesn't get much better than that. This was really a nice example of a patient who was felt to be a non-surgical candidate secondary to just horrific extreme calcific disease that was able to be treated on an outpatient basis with IVL.